Hey, this is Dr. N. Today we're going to be talking about managing autoimmunity. Now, there are, as of right now, estimates are somewhere between 80 and 100 known autoimmune diseases, and there are suspicion that 40 other diagnosed or known conditions may have an autoimmune potential. So you may be listening to this and know specifically what autoimmune issue you have. Certainly the most common autoimmune problem that we manage in our practice is Hashimoto's hypothyroidism. So everything that we're going to say today is relevant to that. In fact, I'm going to say that everything that you're going to see in this presentation is relevant to any autoimmune disease. So it doesn't matter if your autoimmune target is your thyroid or your brain or the joints in your cartilage or your pancreas, or if it's your adrenal system. Autoimmunity is autoimmunity. And we'll clarify what I mean by that in just a moment. But let me go through a couple of caveats before we get started. Autoimmunity is a very complex topic, and it is unfortunately very poorly understood, not just by people with autoimmune diseases, but it's very poorly understood by the average clinician. Depending on which videos you've been watching in your educational process, you may have come across a statement something like, there are no autoimmunologists. Now, certainly we have we have immunologists in medical practice, but there's nobody that is trained specifically in autoimmune diseases. Now, you might say, well, doesn't a rheumatologist do that, or doesn't whatever do that? And they may manage people with autoimmune disease, but they don't actually manage the autoimmunity itself. The medical approach to managing autoimmune disease is typically either do nothing and just use medications to control symptoms, or if they want to work on the immune system, it's to use either high doses of steroids or even anti-cancer drugs in some cases to shut down the immune process itself. Now, we're going to take a different tack. We're taking everything that I'm showing you today is what's been published in the medical literature over the last, say, 10 to 15 years, and it represents our best current understanding of what autoimmunity means, and that obviously gives us some options to start changing what we find. Now, immune research is changing very rapidly, and I would say every 6 months to a year, we learn something different. And because of how rapidly the research is happening in this field, old concepts are constantly being challenged and overturned. And the things that we're doing today to help manage autoimmune issues with our clients, or rather to teach them how to manage their own autoimmunity, what we're doing today is different than what we were doing just a few years ago. And I hope that what we're doing next year is going to be different than what we're doing this year, because that implies we have a greater understanding of a very complex topic. So we're all in an evolution, so to speak. So as I mentioned a moment ago, what I'm going to show you today is a big picture overview of our current understanding of the physiology of autoimmunity. And it's very difficult for me to get a ton of details here, just because everyone's version of autoimmunity is very, very different. And ideally, the detail comes from working through the process. So my job today and my intent is to give you a big picture, to show you the framework, and then trust as we go through the process of working together and doing testing and interpreting not just test results, but your responses, that we're going to have a better understanding of where you fit in within this framework. Now, one of the big things to start out with in the very beginning is that there are no tissue-specific autoimmune protocols. So, for example, I may have 3 clients with different autoimmunities. I may have someone with a thyroid autoimmune issue, someone with MS or a brain autoimmunity, and someone else, say, with celiac disease, which is a gluten-related intestinal autoimmunity. I don't have to have 3 different protocols. Now, I'll end up doing different things for each person just because their version of autoimmune dysfunction is different based on their unique individuality, but I don't have to have a thyroid tissue protocol or a brain tissue protocol or an intestinal tissue protocol, simply because the problem with autoimmunity is not the tissue or the gland being attacked. In fact, when I lecture to doctors on this topic and doctors that are new to this field, I have to make it very clear to them that the tissue being attacked, whether it's your thyroid or something else, is really the innocent bystander, right? We kind of blame the gland. Oh, I've got an autoimmune thyroid. My thyroid's going wrong. Well, the thyroid's going wrong because the immune system has targeted that and it's inappropriately attacking and destroying it. The thyroid theoretically is really doing nothing wrong. It's just the innocent victim. The culprit is the immune dysfunction and the immune dysregulation. And so the best chance of success in controlling symptoms but also protecting your future comes from focusing on the immune system and making sure we're doing absolutely everything we can to regulate a dysregulated system and to remove as many influences or control as many influences as we can that are driving the immune system to be a little bit wacky and to be more aggressive. Now, that does not mean that tissue-specific approaches have no value, but it just means that the vast majority of what we have to do clinically, whether it's with diet and lifestyle changes or with supplementation, has got to be focused on the immune system itself. Now, there are some circumstances where we may use, for example, some nutrients known to help the thyroid with thyroid autoimmunity. But if all I did was give you a thyroid formula or a brain formula or a cartilage formula, but I didn't touch what was going on with the immune system, I'd get very little progress at all. So tissue-specific approaches have their place, but they're not the greatest focus. And I hope you understand what I mean by that. So today, what we're going to do, and remember, this is a big picture framework. I can't give you a lot of details because this has got to be at that big picture focus. But today we're going to go through a simple review of what it means, what autoimmunity means. We're going to talk about triggers and perpetuators. And this is where a lot of the work happens, is finding the things, if possible, that started this process, but things that keep it going, in particular, keep it going more aggressively. That's what we call the perpetuators. We're going to talk about the immune system organization, and then we're going to talk very briefly about why and how we do individualization. Because remember, this is a big picture framework, but we have to fit this framework to you as an individual because your version of autoimmunity is going to be different than everybody else's. So here's the simple review. Autoimmunity as a concept, the term that's used in the medical literature and the immunology research, is a loss of self-tolerance. Now, self-tolerance is a concept that I think is pretty easy to grasp. Like if I have a bacteria or a virus come into my system, that's not me. So my immune system has to know the difference between what's me and what's not me, and it needs to tolerate me and not tolerate not me. So it learns to recognize the distinction between my own cells and a virus or a bacteria or a chemical, and it does things to get rid of the not me things or the non-self things. The problem is with autoimmunity is that the immune system loses that distinction between self and not self, or between me and not me, and it starts to produce antibodies that mislabel my own tissue as something that's not me and needs to be destroyed, like a virus or a bacteria. So we get a loss of distinction between self and non-self, and this is why it's called a loss of self-tolerance. Now, unfortunately, when the immune system mislabels my own tissue as being not me, there's an inflammatory immune reaction that ultimately leads to the destruction of some tissue and therefore a loss of function, whatever function that tissue or those cells serve. So, for example, if the attack is against your thyroid, you lose the ability to make thyroid hormones. If the attack is against the hormone insulin or the cells in your pancreas that make insulin, you lose the ability to control blood sugar and you become a type 1 diabetic. Or if it's against the attack of tissues in your cartilage and your joints, you get rheumatoid arthritis. And so the loss of function is specifically related to the tissue that's being destroyed. But remember, the destruction is coming as a result of the loss of self-tolerance, the loss of the ability to distinguish self from non-self. And because we're dealing with loss of tissue, and I'll show you in a moment that the prevailing model right now is that this is a genetic issue. There is some degree of permanency, and that's really, forgive the language, that's the sucky side of autoimmune disease, is that we don't know how to cure these things, at least not yet. There's no medication that does it. There's no magic supplement from the Amazon or the rainforest or wherever that's going to cure autoimmune disease. But that doesn't mean we can't control it. It doesn't mean that we can't contain the problem. It doesn't mean that we can't put it into remission. But we have to make sure that we're very realistic about what we're trying to do. And it's not cure, it's control and contain and manage. But unfortunately, because there's some degree of permanency and because there are so many different things that have the potential to trigger your immune system, we end up with some degree of progression. So from a clinical standpoint, we have to start with the idea that some of the stuff that you've lost associated with autoimmunity is probably gone, and it's gone for good. But that doesn't mean we can't regain functionality, control symptoms, and then protect your future. But we also assume that there's going to be some degree of progression. And so the right clinical approach would be to limit the progression, meaning that over time, you're going to lose ground. The question is, how much are you willing to give up? Right? If we can call this kind of a game of inches, we want to make sure that over very long periods of time, you lose a couple of inches rather than a mile, or centimeters and kilometers, depending on which country you are as you're listening to this. So again, that simple review of the big picture is that autoimmunity means loss of self-tolerance. The immune system becomes confused about what's you and what's not, starts making antibodies to your own tissue, which leads to destruction and loss of function of the system or the cells and what they are designed to do. And there is some degree of permanency, and we do expect there to be progression, but we need to get busy doing things that protect your future by controlling that process. Now, depending on where you are in the spectrum, like autoimmunity, we can place people along a continuum. We have some clients that have autoimmunity that is very stable and less severe in terms of its symptomatic expression or its disruption of function. And then we have people who have very severe autoimmunity. They have very little control over their immune system, and they're less stable. And what I mean by that is that the least little change or shift in their body function, in things that affect them from their environment, can make their immune system flare up very easily, very severely, and it may be that way for prolonged periods of time. And the question that you need to try to figure out as we go through this, right? And there's no test that will tell me where you are, and unfortunately, we can't look at the severity of your symptoms by themselves to tell us this. We have to ask the question, where are you in the spectrum? And sometimes the answer to that question comes not just by looking at the severity or the number of your symptoms, but it looks at how your body is behaving and responding to things that can trigger your immune system over time. So we may have somebody who comes in and they're very symptomatic and they're just absolutely miserable, but as we work with them, they can, the term I use would, they take a hit periodically. Like they might get flared up, but they recover very quickly. Those people are more stable, they have better control over their immune system than somebody who may have, say, less severe symptoms, but everything affects them. And once they get flared up, they stayed flared up for prolonged periods of time. So as in many things that we deal with in functional medicine, in our unique wellness approach, the understanding of where you are and what your future is going to look like comes from observing things over a period of time rather than just looking at either one variable or one very short time frame. Now, here's just a couple of examples. And again, just you may have different autoimmunities. The most common autoimmunity I mentioned that we work with is Hashimoto's disease. I just want to throw up there just some ideas and some concepts about these antibodies or these labels that are used to diagnose autoimmune disease, and just give you a couple of examples. So for example, to diagnose Hashimoto's disease, we ideally like to see antibodies to thyroid peroxidase or TPO and something called TGB or thyroglobulin. Type 1 diabetics can produce several different types of antibodies. They can have antibodies against insulin, the hormone insulin itself, against the pancreatic beta cells that make insulin, or against an enzyme called GAD65, which is also involved in insulin regulation. It's also involved in producing the neurotransmitter GABA. We may have clients with multiple sclerosis who make antibodies against something called myelin basic protein, or if we're dealing with irritable bowel issues like Crohn's disease or ulcerative colitis, they're making antibodies to intestinal tissue. Now, as I mentioned just a while ago, there are about 100 different autoimmune diseases. And there are some that are very well characterized, some that are not, some that are very common, some that are extremely rare. But the bottom line is, once we know that you have an autoimmune disease, we know that you have it for life. And diagnosing autoimmunity is a matter of measuring these antibodies. But on the right-hand side of the graphic there, I want to point out that once we know that you have an antibody to a tissue, once we know that you're in this world of having an autoimmune disease, remeasuring your antibodies to try to figure out how bad your autoimmunity is really really not appropriate, right? And here's the reason for that. The antibody levels do not tell us how bad an autoimmune issue has become, right? It's really an inclusion-exclusion test. The reality is that the severity of your autoimmunity is not determined by how many antibodies you make, but it's determined by the activation or the lack of control of other parts of your autoimmune system that have nothing to do with your antibody levels. And in fact, we do have clients who have positive antibodies, but they're just barely above the lab range. So they have kind of like low high antibodies, if that makes sense to you, right? They're at the low end of the positive range. And these people can sometimes be absolutely miserable and suffering and very unstable from an immune activation standpoint, whereas we may have somebody else with the exact same autoimmune issue who has very high levels of antibodies at the upper range, but their symptoms are under control and they're very, very stable, meaning there's very few things that can knock them off course and get them flared up. And so we know that antibodies, the number of antibodies you're making does not tell us how bad it is. So I'm not impressed by higher numbers or lower numbers. Once we know that you have an autoimmune issue, we don't, as a matter of routine, keep measuring antibodies and then get all bent out of shape if your antibodies go up by 10%, or we don't celebrate if they go down, just because we know that that's not the determining factor. So I want to make sure that you're clear, because for the doctors and the clinicians out there that don't know anything or don't know very much about autoimmune disease, they make this kind of rookie mistake that the number of antibodies tell you how bad it is, and they keep measuring antibodies over and over again, and that just doesn't help us at all from an understanding or from a clinical management standpoint. Now, here's something to look at, and I'm just using autoimmune thyroid as an example just because it is the most common one that we see in practice. But what's happening with autoimmunity, the big focus is, and the problem is, the immune dysregulation. In this particular case with autoimmune thyroid or Hashimoto's disease specifically, we get antibodies to either TPO or TGB, or you can have both. That ends up in the destruction of the cells where those proteins live, and these follicular cells are the cells that make thyroid hormones. And as the immune system attacks these targets within the follicular cells and the follicular cells get destroyed, we compromise the ability to make thyroid hormones. And so T4 and T3 levels go down, and that means that we don't have enough hormones to activate cells to create what we call proteomic responses, where the cells start making proteins in response to activation, and that leads to the whole plethora. But remember, it's all about the immune dysregulation. Now, from this perspective with the autoimmune thyroid, and this is generally true of other autoimmunities, the focus is down here on thyroid symptomatology and also replacing what's not being made. So for example, with the thyroid, people with autoimmune thyroid that don't make enough thyroid hormone have to go on Synthroid or levothyroxine or Armour thyroid, some kind of bioidentical, to replace what they can no longer make. And that makes sense. That's a good clinical approach if you meet those criteria. Same thing would be said for a type 1 diabetic. Maybe you're destroying insulin or the cells that make insulin. So you have to take insulin because you're not making something your body desperately needs to have normal function. But if all you do is focus on replacing what's not being made, and you don't do something to control the destructive process, then over time the reasonable expectation is you're going to lose more ground and you're going to need more and more medication, and what worked before no longer works, and you're going to continue to get worse and to suffer. Right now, I'm just using thyroid as an example here just to make sure that we're in the mindset of what the process actually entails. But this, you might have MS or RA or something different. Now, something that we've gone through before, and again, depending on which videos you've seen and the educational stream you're going through, you may have seen this before. Let me pause and go through this because this might be the first video you're seeing on autoimmunity. What we see in the medical literature is that autoimmune diseases actually progress along 3 different predictable stages. And these are called silent autoimmunity in stage 1, autoimmune reactivity in stage 2, and then full-blown autoimmune disease in the 3rd stage. Now, antibodies are present in all of these different stages of progression. Remember, antibodies are what tells us that we're dealing with an autoimmune disease, but silent autoimmunity is the very beginning of the process. And that's where you have antibodies and the immune system has started to target your body because you've lost self-tolerance. But because it's so early in the process and you typically have a lot of integrity left in the system, like your immune system can chip away at a system that's pretty intact, and you can take a few hits but still maintain functionality. And this is why in silent autoimmunity, you might have an autoimmune process that's starting, but your symptoms, you don't have any symptoms, and your labs that are associated with that are normal. Again, just using the thyroid as an example, you may have TPO antibodies in your bloodstream, but you have no thyroid symptoms, and all your thyroid numbers are perfectly normal. That's the beginning of the process. Now, we understand autoimmunity to be progressive, and as the autoimmune problem progresses through these different stages, it represents a progressive loss of control over the immune system. And then underneath the surface, regardless of in the beginning having no symptoms, the immune system keeps chipping away at whatever the target is. And then eventually you lose enough cells, you lose enough functionality that now you become symptomatic. And this is what the second stage is, what we call autoimmune reactivity. Now, this is not full-blown autoimmune disease. That's the third and final progression, and that's where the conventional medical system really stands up and pays attention. But in this middle stage, and statistically, there are millions of people with autoimmune stage 2, autoimmune reactivity, that are on their way to the third stage and will probably eventually be diagnosed by the conventional system. But in the meantime, they're completely suffering because in that second stage, you've lost enough functionality, become symptomatic, but you have not lost enough functionality to change the labs associated with that system. And so again, using thyroid as an example, you may have antibodies. Not many docs are measuring those anyways. You have symptoms, but your thyroid panel is completely normal. And this is where people kind of fall through the cracks and get left out in the cold, so to speak, because there's nothing for the conventional mind to latch onto because the labs are completely normal. And this is where we end up getting on what we call the referral runaround, which I'll mention in just a moment. Now, as that immune system dysfunction continues and your immune system keeps chipping away and chipping away, you eventually can end up in the third stage, which is full-blown autoimmune disease. And this is, again, where your medical doctors will stand up and pay attention because not only are you symptomatic and complaining, but now the labs are abnormal because you've lost so much integrity that it changes the tests that the conventional system runs that are associated with that system. So this is where you'll see like a high TSH value. You may see a low T4, and that's where someone diagnoses you with hypothyroidism or with MS or diabetes or whatever the case might be based on the tissue. Now, in the first stage, going back to the beginning of this process where you have an autoimmune problem, but it hasn't progressed to the point where you're symptomatic or changes your labs, then the antibodies then take on what we call predictive value. Somebody may say, well, who cares? You're not symptomatic. Why even measure these things? Well, one reason would be to understand what might happen in your future. Because if you know that you have an underlying process of autoimmunity, you know what's likely to happen if you don't take care of yourself and take care of your immune system. In the second stage, and I'm using thyroid as the example here. In the second stage where somebody's suffering, but there's no demonstrable, conventionally defined disease process because the labs are normal, there's no recognition that stuff is coming from your thyroid because the thyroid tests are normal. There's no recognition that there's an autoimmunity because why would they, thyroid's normal, why measure antibodies? And this is where you end up on the referral roundabout simply because they don't know what to do with you. So you go off to the GI doctor for your gut stuff and maybe the endocrinologist for whatever, who knows, just depends on the situation. And sometimes people in this category, they hear things like, oh, this is all in your head because all of your labs are normal. Now, that's a shame because if they looked a little harder, they would find plenty of things to work on. Now, finally, in that third stage, as I mentioned with the autoimmune thyroid example, high TSH, usually in the third stage, people who get to this point typically need medications. But the unfortunate thing is that there's no focus on controlling the immune system. And so for most people, unless they have, for other reasons, got a stable immune response, they're going to need medications for life, and they may need more as they continue to progress and get worse. Now, what about the second aspect of this? So if we understand this concept of loss of self-control and progression and permanency in the three different stages, what about the things that start it and keep it going? This is what I mean by triggers and perpetuators. And there are some circumstances where we just can't simply figure out how it all started. Sometimes it's very, very clear. For example, we may have somebody come in and say, all of my health issues started after a car accident, or they all started after I was sick and in the hospital. Or a very common one would be, it all started after I gave birth to my second child, right? That's actually a very, very common one. But really, when we look at this concept of triggers and perpetuators, and I'll give you a list of the most common things that we see and what's published in the literature in just a moment, but we have to start with this big picture understanding that the predominant model that explains why people lose self-tolerance is actually genetically based. Right? The prevailing theory is you carry a gene that predisposes you to autoimmune thyroid or MS or type 1 diabetes or something else. And you may actually carry that gene your whole life, but never get the problem unless there's some kind of a trigger that causes that gene to express itself. So if autoimmunity is a genetically based problem in most cases, there has to be a trigger to turn that gene on to create the problem. So again, you may know people who have lived their entire lives with potential autoimmunity, but they had control of their immune systems, for whatever reason, and they never actually got the autoimmunity that could have happened in their lives. But obviously, if you're listening to this, that probably isn't you. And so sometimes going back and looking for the trigger, we can find something very obvious, and sometimes it's not. Sometimes it's an accumulation of, maybe we call them subclinical things. There's no one thing, but it's like a dozen different things over time that eventually made that switch flip to the on position, and now you have an autoimmune issue. So here's a graphical way to look at this. We have to have some kind of an immune or inflammatory trigger, and really those terms are synonymous because most of your inflammation comes from your immune system. And we can roughly divide immune triggers into different categories. Like, for example, diet and lifestyle. You can have an inflammatory diet. You can be eating foods that are you have immune reactions or sensitivities or frank allergies to. Maybe you have a sedentary lifestyle. You're not physically active. You don't breathe fresh air, drink clean water. You're always indoors. You don't get sunshine. Maybe you're chronically stressed. You're not sleeping well. You stay up too late because you're on the internet. All of these things can actually be triggers to an autoimmune expression. And then we have another general category, the environment. And you'll notice that I have ×2 here. Like environment ×2 would be referring to the fact that you have an internal environment as well as an external environment. So your external environment would be things like, maybe chemicals that you're being exposed to, or maybe things that are found inside your food. And this is where we start to blur the lines, right? Because diet is part of the environment, but it's also part of your internal process as well, because it affects the biochemistry of your body. So we have the external environment: pollen, dust, mold, chemicals, clean air, fresh water, that kind of stuff. But we also have the internal environment, which would be things like your gut, your immune system, your hormonal balance, your blood sugar control, right? This whole internal environment can be a rich source of immune activation or the inflammatory response. But nevertheless, if you have sufficient immune triggers to drive that genetic predisposition, and that genetic predisposition, unfortunately, for most autoimmune diseases, there are no gene tests. There's all kinds of information about the genes that predispose people to these things in the medical research, but there's no commercial test that I can order or your medical doctor can order for most of these conditions. But when we try to get a handle on someone's genetic predisposition, we look for a couple of things. One would be to look for a personal history of conditions that are known or suspected to be autoimmunity. So somebody might come to me already having been diagnosed with hypothyroidism, but nobody ever figured out that it was autoimmunity, and 90% of all thyroid conditions are. So you may have been diagnosed and put on medication, but no one ever bothered to look. So if I see someone who's already been diagnosed with an autoimmune condition, but it hasn't been labeled that way, that's a big clue. We also look for family history. We look, for example, somebody comes in with thyroid complaints and 5 people in their family, their mother, their 2 sisters, an uncle, and an aunt all have hypothyroidism. Or maybe it's not a thyroid issue or thyroid autoimmunity, but maybe they have a family history of different types of autoimmune issues. So, for example, this client that I'm talking to has got celiac disease, but other people in their family have type 1 diabetes and MS and rheumatoid arthritis, all of which are autoimmunities. Those personal and family factors increase the probability that what we're dealing with is a genetically predefined or predisposition to an autoimmune issue. Then there's another thing called polyautoimmunity. And polyautoimmunity can exist within a family. That example we gave you before is multiple people with different types of autoimmunity. But we can actually end up with polyautoimmunity within one person. And this actually is a kind of an expected outcome of autoimmune diseases, unfortunately, is that once you get one autoimmunity over time, the longer you go without good control of your immune system, the more likely it is that you're going to end up with more than one autoimmunity. So maybe today it's your thyroid or your blood sugar with diabetes, and then 2 years it's your joints and your cartilage, and now you have RA. And 5 years after that, it's something else, and maybe it's your adrenals and you have Addison's disease, right? So polyautoimmunity is multiple autoimmunity existing within a group of people or family, but usually it's applied to individual people, and the tendency to acquire more autoimmune problems as the immune dysregulation continues to trigger these genetic predispositions. So we have our immune triggers in general categories. We have our genetic predisposition, which is what most of the research is suggesting right now. And then once we trigger this genetic predisposition, what we end up with is a loss of immune balance and control. And this is really what we have to work on trying to regain, is control and balance of your immune system. Now I'm going to throw out some terms here, and we're going to come back to these in a little bit and give you some more detail. But typically, if you look into the medical research, and there are books being written about this now, and there's certainly all kinds of people out on the internet talking about this stuff because they've heard about it in seminars that we or other groups are teaching. But you're going to hear terms like Th1, Th2, Th3, Th17. You may hear about the barrier systems and things like leaky gut or blood-brain barrier issues. And these are things that we'll be looking at and evaluating with you when we can, when there are tests to actually measure some of these things. So, for example, there is no test right now to look at your Th3 capacity or your Th17 levels. Nevertheless, this is what we know about autoimmune issues. But ultimately, it's about this loss of control over the immune system. And once that happens, then we see symptoms and suffering coming about because of losing function in cells and tissues that are being destroyed because of dysregulation within the immune system and the lack of balance and lack of control. So this is a nice graphical way to look at it. Now, honestly, there are other things that I could put in here, but I want to make sure that we spend a reasonable amount of time helping you understand the big picture without inundating you with details that may or may not be relevant to you. And that goes back to saying that, hey, this is a general framework, but you're a unique individual, and what you struggle with may be completely different than somebody else. So what are some of the major triggers and perpetuators that we see? Well, I've already mentioned a couple, but any major emotional stressor, either an acute single event or an accumulation of emotional or psychological stressors over time, whether that has to do with relationships or health and loss of loved ones, or work stress. That's another fairly common one. We see triggers and perpetuators associated with trauma. Head injuries are a very common one, but so would be broken limbs like skiing or mountain bike riding or getting in a car accident. We see it associated with illnesses. We see it associated with significant shifts in the hormonal system. And one of the reasons for this, I'm going to call your mind back to something that we probably have gone over in one of the earlier lessons, is that when we look at the neuroendocrine immune supersystem, how the brain, the hormones, and the immune system all work together to control function, you cannot change the immune system without affecting the hormones and vice versa. So whether you start or stop birth control pill or hormone replacement therapy, say for menopause, whether you just got pregnant or you just gave birth to a child, or whether you're going through peri or postmenopausal changes, those hormonal environments and shifts have implications for your immune system, right? So you can't separate the two. And so quite often, the trigger and perhaps the perpetuator of an autoimmunity would be associated with some kind of change with the immune system. So pregnancy and childbirth. And a lot of times it's not the first child, it's the second or third. And again, that's a pretty common one we'd see. We'll hear women say, I felt fantastic when I was pregnant. I wish I could be pregnant my whole life. Yes, believe it or not, I have heard that for more than one person. Now, we also hear it the other way around. I was miserable when I was pregnant, but 3 weeks later I felt a lot better. So it really just depends on the individual person, but these are some of the more common triggers and perpetuators from that standpoint. Now, ideally, or from a fundamental level, a trigger or perpetuator can be anything that has an inflammatory component, anything that has the potential to affect your immune system or to drive an inflammatory response can be a trigger or it can be a perpetuator for autoimmunity. And this is why we make a real big deal about doing these fundamental evaluations, like doing blood work and maybe doing stool testing or adrenals and saliva tests, is because we need to look for as many inflammatory triggers and perpetuators as we can. Now, I have a list of probably the top 8 that we see. It doesn't mean that this list is complete and perfect. We may find other things with you. This is just to give you that big picture again. So, for example, if you have an adrenal issue, if you have chronic stressors and your body's not handling that well, if you've got blood sugar control problems, whether you've got high blood sugar associated with diabetes or prediabetes and insulin resistance, or whether you've got low blood sugar or inconsistent blood sugar issues like reactive hypoglycemia, if you're eating foods that you're reacting to, if you have a leaky gut, if you have gut infections of any kind, a virus, a bacteria, a parasite, or a candida or other fungal species, any major metabolic problem, any pre-existing diagnosis that you have associated with your health is going to have an inflammatory component. And in fact, if you look in the medical literature, there are 2 things that underlie, and really they're part of the same problem. So let's say one thing that underlies all metabolic issues and all chronic health problems, and that's inflammation and oxidative stress, or inflammation and free radicals. This is what damages tissue, that causes dysfunction, that causes loss of functionality, integrity over time. But anything that can shift your immune system, cause free radical production, cause inflammation, can have the potential to trigger and perpetuate your autoimmunity. And that would include things like poor sleep. In fact, we have plenty of research that says if you have a bad night's sleep and wake up the next morning, you are inflamed. And controlling sleep can reduce inflammation. And we also know, going back to your neuroendocrine immune super system, we know that the brain has control in part over your immune regulation. So if you have a bad brain, if you have had a head injury, you've got some neurodegeneration, or you've got other metabolic issues that affect brain health, you can expect to have a less stable immune system and potentially a more aggressive autoimmune process. And what this does is it gives us a whole lot of stuff to evaluate and a whole lot of stuff to help you work on, to help you learn how to control or eliminate. And some of these things may be things that you have to work on for long term, right? We may be able to control and get rid of things within 2 or 3 months, but you may deal with some of these things for 4 months or 8 months or 12. Ideally, or at the bottom line, it's all about gaining and maintaining control of your immune system and your inflammatory state. And if I can communicate one thing to you, and I probably have said this already to you in our one-on-one sessions, when you have an autoimmune issue, your health and well-being from this point forward hinges on one thing, and that is the control of your immune system and the control of your inflammatory state. The more ways that you can learn to do that, the more control you'll have over your autoimmunity, and the better your health will be in 2 years and 5 years and 20 years down the road. Now let's shift gears now and talk about how the immune system is organized. And please remember that this is a very big picture overview. There are a lot of details. And in fact, if you look at the neuroendocrine immune system, the brain is actually fairly linear and easy to understand once you gain a certain amount of knowledge. The hormonal system, fairly linear, easy to understand. The immune system is not. The immune system is not linear. It is not necessarily predictable. We can try to put the immune system into a box, and we can use several different ways to organize and categorize what we know about the immune system, but the immune system is anything but linear. And it is probably, from an academic standpoint, learning about the immune system is probably the biggest challenge that I personally have had. And I would suggest that all clinicians are in that same boat. But nevertheless, I'm going to give you what we understand right now about immune system organization as it relates to your autoimmune system. And yes, there is a specific autoimmune system that is affected by other parts. So I'm going to introduce some terms. You may be familiar with these based on any reading that you've done on your own. But I want to introduce what's called the Th1, Th2, and Th3 systems. These are really subsets of the immune system proper. And the letters Th stands for T helper. And that is a specific subset or kind of cells that we can further divide. And each of these cells has different roles and responsibilities, but they all work together. They all affect each other. So for example, the Th1 system comprises different kinds of cells that go out and attack and destroy things. So if I have self-tolerance and my immune system knows the difference between me and not me, my Th1 cells can recognize a virus or a bacteria, leave me alone, and go out and kill it. So your Th1 cells actually go out and kill and destroy things. Now the Th2 cells work in conjunction with the Th1 cells because the Th2 cells are how the immune system knows the difference between me and not me. They make these antibodies against a bacteria or against a virus that then labels them as a target, that labels them as not me, so that the Th1 cells can find them and eliminate them. So in a very simplistic way, you have a targeting system and you have an elimination system. You have, in the lectures that we do with our doctors, I describe the Th1 system as highly trained assassins that have no sense of direction and very poor facial recognition. They know they have a target, they just don't know who it is or where to find them. And that's where the Th2 labeling system comes in, because when the Th1 cells encounter a bacteria that's got a label that says, "Hi, I don't belong here," then they know to kill it because they know it's not me. So we have the Th1, Th2 cells working together, but there actually has to be a balance between the two. We don't want one set of cells to get out of control or to get what we call polarized or dominant, because then we don't have the ability to control and fine-tune responses. And this is where the Th3 system comes in. The Th3 system, which is also known as the regulatory T cell system. These are the cells that control the balance between the Th1 and the Th2 subsystems. Right? So we have Th1 and Th2 working together to find and eliminate things that shouldn't be there, leaving you alone. And the Th3 system allows that to be balanced and fine-tuned. And the Th3 subsystem is really critical in maintaining self-tolerance. In fact, a lot of the research is saying that once you lose control of your Th3 system, that's when the lines of distinction between self and non-self become blurred. So improving regulatory T cell function becomes a good clinical target for us. Now here's a graphic, and I'm taking this from, actually this paper is available online if you want to pause the recording and just write down the title of this paper. You can Google that and you'll be able to download a copy. Now it's about autism, but it does talk about the mechanisms of autoimmunity that are common to all autoimmune expression, including autism. The neuroimmunologists are convinced that anything in the autistic spectrum is a brain autoimmune problem, and I would agree with that. But this is a nice graphic that shows how the regulatory T cells in the middle are acting as a conductor for the Th1 system and the Th2 system. Now, I'm not going to go through and describe all of the different things, like the different what are called cytokines or chemicals that are characteristic of the Th2 system versus the cytokines or chemicals that are characteristic of the Th1. I just want you to get this idea or this flavor that Th1, Th2 work together, but they need a conductor. They need to have control and balance, there has to be someone coordinating things. Now, on the right-hand side here, I've got a list of key factors that may, and I want to emphasize the word may, improve your regulatory T cell or your Th3 cell control. And we routinely use these in our protocols. But here's the deal. We have no idea up front, and there's no way to specifically test which one of these things is going to unlock someone's potential, so to speak. So we may find that giving someone adequate levels of vitamin D completely changes their life. But for somebody else, taking vitamin D is a good idea, but it's not the thing that really makes the difference. And so what I don't want you to do is just go out and start taking massive amounts of this stuff. Usually when we're managing clients with autoimmune disease, we spend some time working on these systems, because part of my job as your coach and your mentor is to actually be a coach, but my job is to figure out which of the things might help, will help, right? So this is not a prescription. It's just to help you understand some of the things that may be beneficial for you. And we should be visiting these things as we go through your process and your training, so to speak. So vitamin D, like these regulatory T cells, are loaded with vitamin D receptors. They're also loaded with receptors for your primary antioxidant called glutathione. And glutathione actually is what helps to protect your cells from the inflammation and from the oxidative stress or the free radicals that are produced not just by inflammatory problems, but by autoimmunity itself. So having adequate glutathione becomes important. And again, for many people, it's what makes the difference to them. But for others, we just have to do it, but it doesn't necessarily make a huge difference in their perception of wellness, because there are other things that need to happen. We also know there's tons of research right now on intense exercise as a way to modulate the immune system, but there's a razor's edge here. We know that intense exercise can be beneficial for controlling the immune system, but a lot of people in the beginning of learning to control their immune system don't have the capacity to engage in intense exercise, or if they can't recover from it, and the exercise actually continues to make them worse. So one of the ways that we successfully control autoimmunity is by trying to figure out when is the right time to introduce exercise as a tool, and how can we ramp you up and make sure that you're responding well to that modality, so to speak, right? So again, I don't want you to go out and all of a sudden join a CrossFit gym or go lift heavy weights. Eventually, I'd like you to be doing those things, but we need to make sure that we're putting in your foundation first before we start to implement. Another thing that's really important for your immune system is being social and being happy, actually feeling like people care about you and feeling like you care for other people. This actually triggers what are called opiate responses in the brain. In fact, this is the same mechanism whereby intense exercise helps the immune system, because intense exercise, as well as being engaged with other people, fire what are called opiate receptors. Now, don't go out and take drugs, right? I'm not saying that. Opiates, there are endogenous opiates that you make as a result of being in a social circle, not being isolated, not sitting alone and thinking negative thoughts, or by going out and exercising. These opiates actually activate different pathways in your brain and in your immune system that help promote immune control. Now, the other part of this is that, hey, we can use these nutrients and these lifestyle strategies to help you gain control over your immune system. But what if you've got a whole bunch of diet and lifestyle environmental factors that are significantly shifting your Th1, Th2? Well, it doesn't matter how good your conductor is. If you've got a whole bunch of stuff that's causing a shift between your Th1, Th2 systems, it may not be enough. And that is, I think, part of how we can explain why we can give one person vitamin D or glutathione or have them join a gym and it just changes their lives. Whereas we can do the same thing for somebody else and it doesn't make the same difference. And I think the problem is because there are other things that need to be taken care of first before these other regulatory T cell modulators can have their intended effect. And this is where it's really important to make sure that you understand that as we go through this framework, that these are things that we have to explore. These are things that we might have to do some trial and error on. There is no one size fits all. This is just a framework, and we have to figure out what to do with you as an individual within this framework. Now, continuing on, there are some other players in the immune system as it relates to what's going on with autoimmunity. The first one, next one is your Th17 system. So we've talked about Th1, 2, and 3. Now we're going to talk about Th17, and you can guess by the numbers that there are other subsets, right? So the Th17 actually is your autoimmune system. This is the one that gets you into trouble. When the Th17 pathway gets turned on beyond what we would consider to be normal, that's when it really kicks in your autoimmunity. And this has got nothing to do with your antibody production. Remember what I said earlier, the number of your antibodies doesn't tell us anything other than, hey, you've got an autoimmunity. The degree to which your autoimmunity is active and aggressive is tied up in these first two here. How active is your Th17 pathway, and how much control have you lost over what's called INOS, or inducible nitric oxide synthase. Now, interestingly enough, your Th17 pathway is also your antifungal system. So if we know that Th17 is your autoimmunity and we lose control of that, we do not want to turn it off completely, because if we do, you can't fight off candida or any other type of yeast or fungal infection. So this is all about balance, right? Th17 is necessary. We need it, but we need control of it. Same thing with your Th1, Th2, which tend to get out of balance with autoimmunity. We need them, but we just need them to be in balance. And we can say the same thing about the INOS. Inducible nitric oxide synthase is kind of a chemical group or process that is used by your immune system to kill infections. But when we lose control of it in this context, it causes tissue destruction of me. I lose my thyroid, I lose my brain, I lose my cartilage. That's not okay, but I don't want zero Th17 and I don't want zero INOS. I need control, and I need to be able to maintain that control. Now, part of this is making sure that we have intact barrier systems. Now, let me quickly define what a barrier system is. A barrier system is a division between your outside world and your inside world, right? The reason why we have skin is, well, part of the reason we have skin is so that we don't get infected, right? If you get a cut in your hand and it gets infected, bacteria from the outside world gets to your inside world, and now it replicates and then you get sick. Right? So the barrier system actually includes your skin. I don't have it in the list here. But your barrier system it's an interface that protects your internal environment from stuff that wants to get inside you to do you harm. Right? So bacteria and viruses and fungal infections and parasites and chemicals from the environment. And so when we look at the dividing line between inside versus outside, here's a great visual for you. We as humans are glorified donuts. We have a hole that goes all the way through the middle, right? From the mouth to the other end. Now, the lining of the intestinal system from the mouth to the other end it's what we call mucosal tissue, right? It's a mucous membrane, and that is a significant part of your barrier system, right? So the lining of your intestines is part of your barrier system, just like your skin is. The lining of your respiratory system is also part of your barrier system. And then we're going to throw another one in here called the blood-brain barrier. I just realized that I have a typo on my screen there, so my apologies. Every once in a while they slip through. But the barrier system really is meant to divide that internal from the external environment, just to protect you as much as you can. And so it's the skin, it's the lining of the gut, the lining of the lungs, as well as the blood-brain barrier, which is really the lining of the blood vessels that feeds your brain. Now let's go and take a little bit of a deeper look. When we look at the gut barrier, the medical research calls this the gut-associated lymphoid tissue. And lymphoid is basically just the immune system within the mucosal tissue itself. You may have heard this before, that 70% of your immune system lives in your gut. And that is true. And it lives within this lymphoid tissue. It lives within the lining of the gut, which is a mucous membrane. Now, if you have disruption of this gut-associated lymphoid tissue, you get what is commonly called these days leaky gut. Now, there are no consistent symptoms. I can't look at a client and listen to their symptoms and know for sure that they have a leaky gut, which is why sometimes we have to test for this. Now, and I'll talk about testing in just a moment. But we do know with leaky gut the mucosal system, the lining of the gut, that lymphoid tissue causes, it becomes dysregulated. So we end up with immune dysregulation. Remember, most of your immune system is in your gut. So if you get a leaky gut and you get immune dysfunction in the gut, that actually ends up going systemically, right? The inflammation associated with gut problems and leaky gut doesn't stay in your gut. It goes into your bloodstream where it can affect all tissues, including things like your brain. But not only do we get with breakdown of the gut barrier system, not only do we get systemic inflammation and immune dysfunction, we can also get nutrient malabsorption as part of that inflammatory response, and dysregulation of the lining of the gut will affect the cells that derive nutrients from your diet and deliver them to your bloodstream so you can circulate those around for your cells to use. Now, not everybody has leaky gut. You would think that if you go out on the internet and read these health-related books, you think everyone has a leaky gut, and that's just simply not true. Now, my opinion of leaky gut is biased because everyone I work with is sick, and a lot of people that I work with, because they're sick, have a leaky gut, but that does not mean everyone walking around does. I would say, and I'm going to give you an estimate off the top of my head. I have not done a true statistical analysis of all the tests that I've run, but my off the top of my head assessment of how prevalent leaky gut is among my own clientele is almost 100%. I would say that of maybe every 12 to 15 leaky gut tests I run, maybe one comes back normal, which means that my expectation with the people we work with is that they're going to have a leaky gut. And so we do not always run a leaky gut test. And that oftentimes is just a matter of, say, negotiation or discussion with whomever we're working with. Do we want to assume that's true based on our experience and knowledge, or do we really need to run the test to know that we know? So whether or not we're running and have run a leaky gut test with you is usually a matter of that discussion, which we would have had prior to this point anyways. Now, nevertheless, when your barrier system breaks down, we have to fix it because it changes how you interface with your environment, but it also sets up immune dysfunction, and it changes the behavior of your immune system, and it shifts towards a pro-inflammatory state, and that is system-wide. That's not just your gut, that's everywhere. So give me a person with MS or RA or diabetes or lupus or Sjogren's, and give me another person with any of those diseases and a leaky gut, and the one with the leaky gut invariably has the worst expression of autoimmunity because of the impact of the gut on the immune system, right? So if it's there, we need to deal with it. We need to either assume it's there and fix it, or test for it, confirm it, and then fix it. It's a big deal. And the same thing would be said for the respiratory system, or what's called the bronchus-associated lymphoid tissue, what we might call leaky lung. Now, there is no specific test for this, right? I can't send a blood sample out and tell you whether or not you have a leaky lung, but what I will tell you is that people who have a leaky lung tend to be very susceptible to upper respiratory infections, chronic sinus issues, chronic cough, chronic bronchitis. They may have a history of either frank pneumonia or even walking pneumonia. And if we see that history in somebody's past, then we're pretty confident that they have a breakdown in their bronchus-associated lymphoid tissue. Now, there are some specific things that we can do to try to boost the immune system within the respiratory system itself, but here's the deal. The same things hold true for the leaky lung as they do for a leaky gut. If you have a leaky lung, you are going to be more inflamed. You're going to be more susceptible to infections. You're going to lose control over global inflammatory responses, and identifying this and getting rid of it or dealing with it is part of controlling the big picture of your immune function and your inflammatory state. And then finally, with respect to the barrier systems, we have the blood-brain barrier. And what I said a moment ago was that these are the blood vessels that actually feed the brain itself. Now, for all intents and purposes, the brain lives in a sequestered environment, right? The brain compartment is separate and distinct from the rest of the body because you have a bunch of junk floating around in your bloodstream that has no business being in your brain. Your brain is the most metabolically sensitive system and organ that you have. It is the most precious that you have, so that we have to protect it. Now, when you have a leaky brain, And this is a term that you can find in the medical research. It's not something that I'm making up just to be consistent here. The most common symptomatic expression of having a breach or a faulty blood-brain barrier or a leaky brain is what we call brain fog. And that's a term that will kind of click with some people. In fact, a lot of people use that when they try to explain to me what's going on inside their head. Some people don't really know what that means, and I would say that brain fog is kind of like it's like having a veil over your thought process. Like there's no clarity, there's no focus. It's difficult to think through problems or to assess things. And so brain fog is probably the most common expression, but we can throw in things like poor focus and concentration there as well. So much so that when we hear the words brain fog or some kind of description like that, we automatically assume that leaky brain is a possible thing, and then we need to either test it or assume it's there. Now, the testing here is actually pretty easy. We can do a leaky brain lab test. The same lab that does our leaky gut testing and a lot of our autoimmune testing, called Cyrex labs, they have a fairly inexpensive leaky brain test, which is a blood test looking for antibodies to proteins that are associated with the blood-brain barrier as it breaks down. But what we have found is that doing what we call a GABA challenge is pretty clinically relevant, and I have over the past year or so run leaky brain tests and GABA challenges on a lot of people, and the correlation is very high. So I have come to the position clinically where unless somebody really demands that they want the blood test, we'll do a GABA challenge. Like when we see brain fog as a presenting problem, we'll do a GABA challenge. Now, I'm not going to explain what that is here. That would be appropriate in a different venue. And if we have decided to do that with you, you probably already have the instructions and may have completed that already. But nevertheless, I just want you to know that when we look at the contribution of the barrier systems to either good control or poor control of your immune mechanics and your inflammatory state, we have ways to assess that. And of course, that translates into what do we do to try to fix it. So how does all this fit together? So, we've talked about Th1, 2, and 3, Th17, and I and OS. We've talked about your barrier systems. We talked about immune triggers and perpetuators. Here's how it all fits together. But I want to make sure before I show this to you that I reiterate this is our best understanding today. This might change. Now, we're not going to have to pull out a big element and go, oh, we were completely wrong. If this model changes, it will be because we understand things here in a deeper or different way, or there are things that we're going to add to this model that we're just not aware of yet. And going back to that idea that research is just exploding in the world of immunology over the last several years. So here's how it all fits together graphically. We have immune and inflammatory triggers that then can overwhelm your cellular protection series or systems. And in here we have our genetic predisposition to autoimmunity. But when we have sufficient inflammation and free radical production, we overwhelm our ability of things like glutathione, which we mentioned before, our antioxidants. We overwhelm our ability to protect our cells. And when we lose our ability to protect our cells, we kill the cells and we kill the function that's associated with that. And in particular, we start to lose our barrier system. So when you're chronically inflamed and you can't protect the cells of your gut, you can't protect the cells of your lungs, you can't protect the cells in your blood-brain barrier, we lose that barrier system. We lose the interface. And the medical research says of the gut barrier particularly, that it is a trafficker. It's kind of like a traffic cop and a regulator of your immune responses. So when we overwhelm tissue protection and we lose the integrity of our barrier systems, that is what tends to drive our Th3 conduction system out of balance. And now we can no longer control our Th1, Th2 systems. And so what we tend to find with autoimmunity is that someone may become Th1 dominant. They don't have that balance, or they might become Th2 dominant, or we may actually lose both systems. And so we can't either mount a response or we mount an aggressive one. But nevertheless, when we lose control and regulation, we get some kind of Th1, Th2 dysregulation. That is what turns on your Th17 system. That's what takes your Th17 system from being your normal run-of-the-mill antifungal process and puts it on steroids, and now all of a sudden it starts going around wanting to kill you. It wants to kill your thyroid, your brain, your adrenals, or whatever the case might be. Now, here's the deal. The Th17 system is kind of like your mafia boss. It doesn't do the dirty work. It has a hitman to do that. And the hitman for your Th17 is your INOS system, right? Your inducible nitric oxide synthase. And this is still a normal process, right? We need the INOS system for the immune system to kill critters like bacteria. But just like when the Th17 system upregulates and gets out of control, we get an exaggerated INOS response. And this is what causes the actual tissue damage and destruction of the autoimmune system. So whatever tissue has been targeted gets whacked, so to speak. Now here's the problem, is that once you create the tissue damage, once you fire up your Th17 and your INOS pathways, these things then become their own trigger and perpetuator. So we get a vicious circle where even the initial trigger may be gone. Like maybe it was an emotional response, maybe it was an injury, that's all resolved, but now you're locked into this process where that initial event caused a complete loss of control over your immune system. But when you lose control of the immune system, you become more systemically inflamed, and the tissue damage and destruction associated with the autoimmunity becomes its own perpetuator. And it just keeps triggering this ongoing autoimmune process. So we have to have some kind of a methodology to go into this framework for you as an individual and figure out where the system is breaking down and start running the right tests and doing the right things and engaging in a little bit of smart trial and error to figure out what's going to work for you. And now we have many different things that we could do to help control autoimmunity. The question is, what's going to work for you? And that's why sometimes it takes 4, 5, 6, or 8 months to learn how to control this stuff and to get some ground. Now, the final element here is individualization. And I've already mentioned this. There can never, ever, ever be a one-size-fits-all prescription for autoimmunity. There are just too many variables to predict, and there's too much variability within individuals with autoimmunity. And in fact, we're not treating autoimmune disease. We're managing people that have different expressions of autoimmunity. So we have to look at you and your specific situation. What are your triggers? What are your perpetuators? And that should bring back to your mind all of those general categories like diet and lifestyle, environment times 2, your barrier systems, what's the control of your regulatory T cells? Do you have a Th1, Th2 dominance pattern? How do we figure that out? What's your glutathione status? What's your vitamin D status? And there are things that we don't even know yet that we're going to know next year and 2 years and 5 years down the road. So this is a continually evolving model and approach. But as I mentioned at the very beginning, this is our best and current understanding. And believe me, when I say that there are no autoimmune immunologists, what I've just shared with you, I can almost guarantee that your medical doctors do not know what we're talking about here. Like if you can watch this over again and just get a good grounding in this process, you will be so far ahead of the average practicing clinician, not just medical doctors, but all of the alternative clinicians out there. They just don't know this stuff because they're not reading the medical research and they're not going to the seminars where we're teaching this stuff. So here's my final word. I have to be a coach. And maybe sports analogies don't work with you, but just bear with me for a moment. Let's say that I'm a basketball coach and I know that next week I'm going to go up against a team that's really tall, fast, and strong. Well, I've got maybe a group of 10 guys, but I have to pick my 5 best players to beat that team next week. And they might be a different group of 5 players that I had to use to beat the team before. So maybe last week I played a whole bunch of really short guys who could shoot long distances from the outside. And next week I'm playing a whole bunch of tall guys who are really good close to the basket, right? I, as the coach, have to be smart enough to play the right players to beat the different opponents. And so my job is to figure out what your best team is, or to help you figure that out would probably be the better way to do that. And so I want to caution you against just blindly going out and taking large amounts of some of these nutrients that we've talked about, right? That may or may not work for you. And usually by this point in your progress, we've at least visited those. And sometimes we do some initial work and then we work on other things and we come back to these. Ultimately, at the end of your process, the end of your program, we should have an understanding of what your maintenance program looks like, right? So, maybe there are 3 key nutrients or strategies that work for you to control your autoimmunity. And those 3 things that you do might not work for somebody else, and someone else only needs one, and it's something different than what you're doing. So again, there is no one size fits all, and this is a process of understanding and application and trying to figure out what's going to work for you, not just today, but to help protect you for the next 20, 30, 40, 50 years, depending on what time you have left. So I hope that you found this valuable. And yes, I understand that there was a ton of information here, and this was a rather long lesson. Let's make sure that we clarify any questions that you might have in your one-on-ones, and we'll talk to you again soon.